and my slides are visible.
Yes, Shivakumar.
Thank you very much, madam, and thanks a lot to the organizers and the panelists and the chairpersons for giving me this opportunity to talk about operating room protocols and documentation. Nowhere else is this dictum more appropriate than in facing a case of endophthalmitis. Prevention is always better than cure. And we know that prevention of endophthalmitis starts with a good OT infrastructure according to specifications laid down by various organizations, and also the HVAC, heating, ventilation, and air conditioning specifications and air handling units. So these specifications also help in preventing. But more important is a thorough cleaning and disinfection in the operation theater. And the most important is a meticulous cleaning and sterilization of the instruments. So we know that the prevention of infection is based on three pillars of cleaning, disinfection, and sterilization, where cleaning is the removal of dust and foreign particles from the surfaces of the floor, fixtures surrounding the surgical area, and the disinfection is removal of most of the pathogenic microorganisms, and sterilization is removal of all microorganisms, including the spores. So we come first to the cleaning and disinfection protocols, and we know that this is to prevent the contamination of the surgical field. And we know that the high-touch areas in the operation theater, they should be cleaned more frequently by the right person. That is the person who is well trained to do this at the right intervals, depending upon whether they are high-touch or low-touch areas, and with the right material. The commonly used disinfectants are contain benzalkonium chloride or sodium hypochlorite, and the intervals can be daily, weekly, or monthly, depending upon the status of the area. So the daily cleaning is usually done for the OT floors, walls, all fixtures and equipment. And having said this, we need to keep in mind that only about 1% of the microorganisms on the floor and on the walls are pathogenic. The weekly cleaning involves all these structures, the floor, walls, and fixtures, and also the ceiling and AC filters. And the monthly cleaning is for the less accessible places, the nooks, corners, and the RO water tank and the AHU filters. Fumigation is now a fading practice, especially with formaldehyde. There are alternative solutions available like Emodil, Vastosil, and Bicron. But then ideally it is indicated only if a new operating room is commissioned after 3 consecutive negative culture reports, or if you are starting an operating room after construction or repairs. And if we have an AHU with a HEPA filter, which is kept on for 24 hours, with the AC not functioning during the time that surgery is not on. But if the AHU is on for 24 hours in the blower mode, no fumigation is needed. Coming to the cleaning and sterilization of instruments, which is probably the most important part for prevention of endophthalmitis. It is imperative because these instruments come in direct contact with the eye, and special attention is to be given to the cannulated instruments. And these instruments which have been used should not be allowed to dry, because it is difficult to remove the organic material and the debris which stick to these instruments. So the preliminary cleaning should be done with RO water, and then should be subjected to ultrasound cleaning for 3 minutes, which helps to dislodge the debris and the organic material. And then a sequential cleaning is done in 3 basins of RO water, and this water is collected through a 0.2 micron filter. And the first basin, a soft toothbrush, is used to meticulously remove all the debris, and then 2 more sequential rinsings are done. Equally important is the drying of the instruments, especially the cannulated ones, because the damp or water-containing cannulae do not get autoclaved or sterilized properly. Also important is the proper packing of these instruments for autoclaving or for chemical sterilization, because if they are too closely or tightly packed, this may not happen properly. As far as cannulated instruments are concerned, the Simpo is to be flushed with 10 cc 5 times, hydrocannula 5 cc twice. The phaco tips and sleeves and IA tips 10 cc 5 times. Phaco and IA handpieces should be flushed from both the irrigation as well as the aspiration ports with warm RO water 20 cc 10 times, and an equal amount with air so that they can dry. The sterilization of instruments should be done, if possible, by a dedicated CSSD team or with well-trained staff, and they should follow the validation protocol. There should be unidirectional flow to avoid any mishap or mix-up of material, and it should be from the unclean to the clean to the sterile area. The sterile items should be stored properly, and there should be no mix-up. There should be a strong recall policy, and if there is any doubt, it should be considered as unsterile. Then coming to the sterilization validation, which is the most important documentation and oral surveillance protocol, we use chemical indicators. The class 1 indicators are used for steam autoclave as well as for ETO. And this is a 3-line tape with the initials of the operator, the load number, the autoclave, and the date of sterilization and the date of validity. And this is placed in every set, every bin, every load, and at various levels in the linen bundles. The class 5 indicator steady gauge, which we saw, is placed in every load over the bins in every cycle, and in every bin at the top, middle, and bottom to ensure proper sterilization throughout the bin. And class 2 indicators should be there for ideally every load, the Bowie test as it is called, and at least once a week for each autoclave so that we know that it is functioning well. Also for the functioning, we have the biological indicators. For the steam autoclave, we have the Geobacillus stereothermophilus and Etiobacillus atrophius, and this is done once a week. The OT microbiological surveillance may probably be dealt with later in another talk, but the OT environment should be checked once a month, RO water twice in a month, and irrigating solutions and viscoelastic before we start using the new batch. Now coming to documentation, which is the most important aspect when we face an endophthalmitis or a cluster endophthalmitis, because documentation will help us in tracking back to find out any deficiency or lapse in the sterilization or the cleaning process. So this is a documentation for cleaning and disinfection. We can see that a register is maintained with the time where the cleaning has been done in the different areas, who has done the cleaning, and then the end of the day cleaning of the entire OT. And it is countersigned by the sister who is supervising them as well as the CSSD sister in charge. Now, this is a checklist for all the OTs and the surrounding areas and the areas outside the OT. This checklist helps in avoiding the missing out of any of the fixtures or areas. And this is for 5 days of the week, and another checklist for the Sunday with additional areas like the AC room and the dress changing room and other rooms. So these checklists help to make the cleaning thorough, and it is countersigned by the supervisor. This is the schedule for the AHU filter cleaning schedule and the raw water tank cleaning schedule, which is done once a month and countersigned by the infection control in charge. Now, documentation of sterilization validation is probably the most important when it comes to finding out deficiency in sterilization. So here is the printout from the automated autoclave, and you can see that the different cycles have been marked out. And the operator has found out if the minimal temperature is above 121, and if the fluctuation between the highest and the lowest temperature is within 2 degrees centigrade. It is signed by the operator and countersigned by the CSSD in charge. This is a register containing the steam sterilization monitoring. This is the steady gauge from each of the cycles from each of the autoclaves, and this is from each of the cycle from the in-between sterilization in the high-speed autoclave. Similar 3-line tapes from each of these cycles, but this also contains the time of which the cycle, the timing of the cycle, as well as the person who has carried out the loading and the unloading. And this is another register again with a 3-line tape, and this shows all the bins from which OT which has been loaded in that particular cycle, and this is for each of the autoclaves. So these records help in tracking back as to which load or which cycle could have been defective. Now, this is a similar record for the ETO sterilization, where we have the entire ETO cycle as well as the indicators that the sterilization has been completed and what are the materials which have been sterilized in that particular cycle. A similar manual record kept as to which material from which OT has gone in for that particular cycle. And this is a register which is maintained of sterile packs which have been removed from circulation at least 1 week from the expiry of sterilization. So it usually is valid for 1 month, and this is taken out 1 week prior to that 1 month so that we don't use expired material. Now, this is one very important documentation maintained by every operation theater, where the 3-line indicators of every bin that is used in that OT on that day has been stuck, and also the steady gauge class 5 indicator and the ETO indicator. And A close-up will show that the temperature and humidity has also been noted. And this is the list of the consumables or the injections, intracameral injections, which will be used on that day, along with the batch number. So it is easy to trace this back. This is a 3-line indicator of every bin during the in-between sterilization from the high-speed autoclave. And this is the most important documentation. On the patient's case sheet, the 3-line indicator from that particular set is attached so that we can always trace back based on the name of the operator, the autoclave, the load number, and the theater. So, and this is a very important documentation, which is called the recall register. And any lamps in sterilization or any deficiency is noted, and the corrective action is noted. And this is countersigned by the infection control in charge and is closely monitored. This is the result of the Bovidec test, which is done on a weekly basis for each of the autoclaves. And this is a record which is maintained for the biological indicators from each of the autoclaves, ETO, as well as from the other autoclaves. And this is promptly countersigned by this infection control in charge. Finally, the documentation of surveillance, we have the OT culture reports every month, and if there is any discrepancy, any deficiency, then it is highlighted, and comments are made by the infection control in charge on real-time basis so that corrections can be done. This is the water culture report, which is taken once in 15 days, and this again, is countersigned by the infection control in charge. And this is the RO water analysis, chemical analysis, which can be done at a lesser frequency, but we do it at once a month. This is a record of the pH values and the culture report of various consumables when a new batch is started for BSS and for viscoelastics. And this is also kept and countersigned by the infection control in charge. To conclude, cluster endophthalmitis can be prevented by adequate training regarding these protocols and making sure that these protocols are strictly adhered to, by monitoring that adherence and having evidence-based revision of protocols whenever it is needed, and having a meticulous documentation so that we can go back and find out any deficiencies. Thank you very much.